Hi, part-time 4. This is the video of the active hip assessment that we looked at the last part-time weekend. And this was a hip assessment that was taught to me by Dr. David Tiberio of the Gray Institute. And it's a really useful hip examination, baseline hip examination, but it also introduces us to a couple of useful treatment strategies as well. So, we started by looking at what you do already in terms of an active hip assessment, and for the most part, not exclusively, the ideas were involving things like, if I'm examining the right hip, external rotation, internal rotation, flexion, extension, abduction, adduction, that kind of thing. And we talked around that, and I said that I thought there were several disadvantages to that. It's not that you would never do that, and in some instances, particularly if the task or the thing that that patient did involved that type of movement, that would be a really valid thing to examine. But for the most part, I think it has a few drawbacks. One, it involves me in quite a lot of muscular effort to get to end range in those movements. And it's also difficult to isolate. It's sometimes something like extension, to coach your patient as to where exactly to end that motion, combined with the muscular effort, I think is quite tricky. The second thing is, I think it can also be quite difficult to measure. Because you're doing one side at a time, you've got to get a visual read on that, and then you've got to compare it to the other side. Not impossible by any means, but does present a problem. But most of all, I think for me, it's because it's not a terribly functional movement. And in our active assessment, we really want to see how the body is functioning when that person is upright, moving, walking, stepping, doing that which they do in daily life. And in daily life, generally, the hip is driven by the rest of the body. So something we do creates movement at the hip as we take a step or we reach around. We have gravity acting, there's a ground reaction force, and in addition to that, we want to kind of be able to take in what the rest of the body is doing. So when we're looking at the hip, we're not just looking at the hip in the active examination, we need to observe what is happening to the rest of the body, and we'll come back to that a little bit later. So, we started from there. We talked about, well, what could we do about that? And some of you said, well, we could do a squat then. So we could assess flexion at the hips by getting our patients to squat. And that's not a bad thing to do. But again, that has a limitation. The limitation being that, supposing my right hip has a limitation in flexion, well, I'm going to stop my squat. I'm only going to go as deep as my right hip allows me. So I didn't really get to see what the left hip could do, and I don't really know if there's a difference between the two. And the same applies to something like rotation. So if I use the arms to drive me around into rotation, I'm internally rotating the left hip. However, I'm creating external rotation because my pelvis is moving over my femur, which is the same as that happening. And I don't know, if I only get to here, well, and I'm expecting more, is that a limitation of my left hip or internal rotation, or my right hip's external rotation? So, we came up with a strategy, or actually David Tiberio came up with a strategy for overcoming that problem. And the strategy is to pre-position the hip, or one hip, so that it doesn't approach end of range of motion, so that when you create the motion, you're only testing one hip for one motion at a time. So if we go back to our example of flexion, what could we do? We could position the right hip, the right foot forward of the left, the left foot forward of the right, and if I then get my patient to reach forward in front of their knee, like so, well, I started in a bit of flexion, and this hip is getting all the way down as far as it can go into flexion. But this one has started in extension, and while it's flexing somewhat, it's gone nowhere near its end of range. So I'm assessing the left hip hip's ability to flex. And then I could do the same on the right hip, and I can compare the sides. And so we said, well, what can we do for extension? Well, we can do the same thing. So I can pre-position right foot forward, and I'm using arm drivers here. We're using arm drivers, we'll come to that later, because you may not want to use arm drivers, and we talked about this. What would you do if you had a patient with low back pain? Well, we probably wouldn't want to drive through the low back. We'll come back to that. But in this instance, let's just use arm drivers for a minute. So with pre-position, what can we do? This hip's in flexion. This one's already pre-positioned in some extension. If we drive the hands back overhead to take the pelvis into posterior rotation, I get to the end of extension of my left hip, but my right hip hasn't really even got into any extension. So I'm testing my left hip's ability to extend, not really doing too much to my right hip right now. What do we do for internal and external rotation? If we want to look at internal rotation, we can pre-position the feet turned inwards. Now I'm going to drive with my arms round into rotation. So if I go round to the left, I'm internally rotating my left hip, pre-positioned the right in internal rotation, so that's kind of getting to neutral now. So I'm testing my left hip's ability to internally rotate, and I can compare that now with the right. You get a really good visual read on the pelvis. How far round does the pelvis go? You can also get your hands on. That's a really useful thing to do. If you can't see it, feel it, get your hands on, follow the motion. Then we did external rotation, turned the pre-positioned in external rotation. And if I go round to drive round to the left, that's driving my pelvis left. I'm externally rotating my right hip. Haven't really done too much, haven't gone to end of range of my left hip. And we get a read of how far around that pelvis goes. We can get our hands on, then we go around the other way. And we saw, actually in my hip, that I don't get as far around this way. Don't necessarily look at the hands, because that can be misleading. We really want to look at the pelvis. Okay, so we saw that I had a limitation in my extension of my left hip going around this way. Coming back to the point earlier that I made about looking up and down the chain and the benefit of doing this type of assessment because of that is we noted when I went round here, if I really pushed round, what happened to my knee? Because actually I could cheat that motion, I can still get round there, but my foot, actually it's my knee first of all that caves in, and then my foot comes up off the ground somewhat. So you've got to be taking that in and looking for that. Not just be too fixated on what the hip's doing. But that also gives you great insight to what this hip might be doing to other parts of the body. So, does my knee get affected by my hip? Yes. Can you see that when you do a hip assessment to see the limitation in my hip? You bet you can. So, where do we go from there? We looked at abduction and adduction. So, what do we do for abduction? We pre-positioned in an abducted position. We took the arms and we drove overhead, letting the pelvis translate to the side. And we look, now I'm abducting my left hip, I'm testing my left hip's ability to abduct, and now I'm testing my right hip's ability to abduct. Haven't really done too much to the left hip. And if we go into, we want adduction, then I go narrow, and we went that way, testing adduction of my right hip, adduction of my left hip. And I've skipped through that fairly quickly because I think you've got the gist of this. Okay, so that was essentially a fairly comprehensive active hip assessment.